Richardson from Fayetteville, Representative Pat Hurley. I saw Senator Quallick come in. Oh, there you are. We'll make sure I don't miss anybody. Oh, okay. Representative Hurtado from Alamance County. But anyway, there will be several speakers today and a lot of information. Right now, I will turn the program over to Frank Lester with the Treasurer's Office.
Good morning, everybody, and thank you all for being here. Thank you, Representative McNeil, for all your help and leadership on this issue. And we really appreciate everybody. We know there's a lot done. We're here today to talk about the release of our report, Hospital COVID-19 Profits. It was researched and written by the State Health Plan, the National Academy of State Health Policy, and peer-reviewed by academics at Johns Hopkins Bloomberg School of Health. You all might have also seen there was a full-length article in the Washington Post today that highlighted that this study. So I encourage everybody to go to our website and take a look at that. I hope you find today's press conference and report informative and compelling. Let's see. I do want to go ahead and thank Treasurer Falwell up front for his leadership in this space and his laser focus on the solvency of the State Health Plan. Joining us online today are Marilyn Bartlett, CPA, Senior Policy Fellow at NASPE. Mrs. Bartlett is a legend in healthcare analysis, and we're truly appreciative of having her work with us on this report and being here today. Also, we have Dr. G. Bai, who is Professor of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health, Professor of Accounting at the Carey Business School. She also peer-reviewed this report. Thank you, Dr. G. Bai. And we also have joining us is Dr. Dale Owen, who's a cardiologist and CEO of Tryon Medical Partners in Charlotte, the region's largest independent medical practice. Thank you for being here, Dr. Owen. We know you're all very busy, so I will be quick and try to get to the meat of this presentation. But as we were preparing for this press conference, I thought it would be a good opportunity to let you all know the context and answer the very fundamental question of why did we do this? Why did we start looking into this issue? As you all know, the State Health Plan has about a $34 billion funded healthcare liability. During the pandemic, it provided free COVID testing and treatment for all 750,000 members of the State Health Plan. It literally spent hundreds of millions of dollars on this treatment. While the governor and the General Assembly reimbursed much of these expenditures, the strain on the plan was severe at times. We began to ask several questions as this was going on. As we watched the billions of dollars being pumped into hospital systems, some of them very large, some of them that we knew had billions and billion dollars of reserves, we started asking some very fundamental questions. We were like, did these big hospital systems with all these reserves really need the money? What was the large hospital's profitability during COVID? I mean, fundamentally, what happened to the hospital industry during COVID while this money was being pumped into the system? Were rural hospitals treated equally? Were they? Did they get the same amount of money? How did it impact hospitals' charity care? What we found out literally shocked us, and I think it'll shock you all too. Before we go on, and you know you all really want to hear from the researchers and Treasurer Falwell and other legislators, but a couple of housekeeping items, please. Reporters that are online, please use chat box to ask your questions. Julie will manage the questions online and here in the room. All reporters, please identify yourselves and your media outlet when asking questions. In addition, any legislators who want to make some comments or ask questions, will be plenty of time near the end where you all can ask whatever questions you may need to do. I think that's it. So thank you all for your time, Julie.
Hello, thank you so much, Frank, and thank you everyone for joining us today. We're here today to talk about what happened with the COVID relief and about the hospital systems that scored record profits during the pandemic and about the patients, doctors, and rural hospitals that suffered. At the state health plan, we analyzed our state's 7 largest hospital systems, audited financial statements with the help of Marilyn Bartlett from the National Academy for State Health Policy, and Dr. G. Bai from Johns Hopkins peer-reviewed this report after it was finished. What we found was stunning. One hospital's 41% net profit margin exceeded the net average margins of tobacco and investment banking during the pandemic. Another hospital made almost $2 billion in 2021 while suing patients over medical debt. Together, the 7 hospital systems took the lion's share of the COVID relief and then reaped a $7.1 billion growth in cash and investments, again, during the pandemic, a number almost equal to the state's appropriations for K through 12 classroom instructions in 2020. That's not even counting another $5.2 billion in net profits in 2021 alone. Hospitals' charity care spending did not keep pace. It actually fell across a third of hospitals during 2020, even as thousands of North Carolinians lost their jobs. You're going to hear from the treasurer about how the largest hospital systems took $1.5 billion in COVID provider relief and another $1.6 billion in Medicare advance payments, and why we believe these hospitals owe it to their communities to use this money for their patients, not for their profits. Treasurer, please take it away. Thank you.
Thank you, Julie. People, when I walk into the legislative building, I always have a satchel full of papers, and people say, why do you bring all that? And the answer is because I say things that unless I showed them to you, you probably wouldn't believe. So I appreciate all of you being here today to actually see not just the words that are on paper, but the dollars that are on paper associated with that. Let's be very clear from the outset. This isn't about the healthcare workers. This isn't about the people who actually do the work of healthcare in this state. This is about the multi-million-dollar lobbyists, the multi-million-dollar executives who run these multi-billion-dollar corporations who don't pay sales, real estate, and property taxes, who disguise themselves as nonprofits. Why should you care? The reason you should care, no matter what political party you're a member of, what race you're a member of, or what gender you're a member of, you should care about the massive transfer of wealth that's going on in this state from the citizens to these multi-billion-dollar nonprofits. You should care about that. You should also care when we start talking about these billions of dollars. For example, Atrium has nearly $12 billion in the bank this morning. That is nearly half of the state budget for 1 year. That's how much money they have in the bank. And you should care about the fact, very simply, that they didn't get $12 billion by selling groceries or making widgets or developing software. They made $12 billion on the backs of taxpayers. And you're getting ready to hear more about that. Over the years, especially over the last 10 years, there's been a Pulitzer-nominated report that has come out from the News and Observer called Prognosis Profits, and you're about to see a lot of that over the next few minutes. Then the Assembly NC just did another recent report refreshing some of what's going on regarding the profits. I want to close my remarks by telling you that we have done everything we possibly can on the issue of how we get more out of less from our state health plan. Former Treasurer Harlan Bowles warned us about this 37 years ago. Bill Gates warned us about this 15 years ago. State Auditor Beth Wood warned us about this 12 years ago. Warren Buffett 4 years ago warned us about rising healthcare costs. Senator Elizabeth Warren, in a presidential debate 3 years ago, warned us about this. What are all these people in the State Employees Association has been talking about this for at least 10 years? Generally speaking, what do these organizations have in common, especially the elected and the appointed officials? They're all Democrats. I'm not. This is not a Democrat and Republican issue. This is a moral issue. And the fact is that we've done everything that we possibly can inside the state health plan to cut our cost. We've renegotiated all of our contracts for our Medicare Advantage, which is going to save $1 billion over the next 5 years. We've just renegotiated our pharmacy benefit management contract, which is going to save $800 million over the next 3 years. Until we break this healthcare cartel, and I was called last week and by someone who said, we'd really appreciate if you'd stop using that word. I'll tell you exactly what moment of what day that I'll stop using that word is when they stop acting like one. Cartels control the quantity of a product. They control the quality of a product. They control your access to the product. They control the price of your product. And as you've heard over the last few weeks, if you don't pay for this product you didn't want to consume, then you're punished and your credit score is weaponized. I just got a call on the way over here from a gentleman whose credit score went down 50 points, a young person under the age of 30, because of a $10 copay on a COVID shot. This is really what's happening across North Carolina. So with that, I will just tell you the consequences of us continuing to have secret contracts in this state, our unwillingness to push the power to the consumer so the consumer can figure out the price and the value of what they're getting. The consequence of that is going to be more and more money being transferred from the citizens of this state to these multi-billion-dollar corporations who disguise themselves as healthcare companies. And I can tell you in my closing comment to you, we're now in a situation where people cannot see themselves out of their poverty, not because of acts of God, not because of acts of COVID, not because of lots of other things going on in our society right now, because of their fear and what's actually happening to them regarding rising healthcare costs. So thank you. And Julie, I'll be ready for the next presenter.
Sorry, I turned it off. I'm now going to let Dee Jones from the State Health Plan say a few words. She's responsible for the healthcare for about 750,000 State Health Plan members, retirees, and their dependents. Thanks so much.
Thank you, Julie. Treasurer Falwell and distinguished guests, thank you for all being here today to discuss this really important topic. I'd like to congratulate the Treasurer, Frank Lester, Julie Havelock for completion of this work product. I'd also like to thank Marilyn Bartlett, Dr. G. Bai, Dr. Dale Owen, Nashby, and Representative McNeil for the unwavering support. The State Health Plan has been on a mission to support and promote healthcare transparency and affordability for years. The report is not published to criticize the hardworking healthcare professionals and support staff that take care of us when we need help. This is about the healthcare system as a whole and the desperate need for change at the highest levels to ensure affordable, efficiently delivered, high-quality healthcare. This report is about being transparent and bringing this information to the public and our plan members. To be an educated healthcare consumer, it is critical to understand the topics and healthcare itself. It's also important that this information be shared and shared widely and discussed so we can be part of a much-needed shift in how the healthcare system works to serve our communities. Thank you again for being here today, and I'll turn it back over to Julie.
Thank you so much. I'm now going to turn it over to Marilyn Bartlett, who's a CPA and a senior fellow at the National Academy for State Health Policy, Center for Healthcare System Costs. She is the one who helped us analyze all of this data, and she's a bit of a legend in the healthcare community for her reforms in Montana. Marilyn, please take it away.
Thank you, Julie. Treasurer Falwell and the rest of the group in North Carolina. I'm here in Montana, and I'm glad that I'm able to join you today. I appreciated being able to work with your team. We delved into the audited financial statements and some other filings that are public information to really try to find out what was the world like for these health systems pre and post COVID. How did they stand from liquidity and financial stability. And the results that you see in this report and the references are from their audited financial statements for the most part. What we see here, we see in other states also, and so we were very glad to be a part of this project. Thank you.
And I'm also going to turn it over to Dr. Ji Bai, who is a professor of accounting at the Johns Hopkins Carey Business School and a professor of health policy and management at the Johns Hopkins Bloomberg School of Public Health. She helped peer review this report, and she's very well known for her research into hospitals' profits and charity care and community benefits. Thanks, Ji.
Thank you so much, Julie. Thank you, Chair Falwell, for giving me this great opportunity to review the report and also be here today. So this report is very revealing. Simply speaking, we found the North Carolina taxpayers are hit by a double whammy. The first whammy is that the federal government channeled taxpayers' money to the rich and the powerful hospitals, especially here in North Carolina. No, they did not really need the money in the first place. So this is the first whammy, that taxpayers' hard-earned money is being wasted. Right? The second whammy is that these rich and powerful hospitals use the windfall money to engage in mergers and acquisitions, to consolidate their market, to strengthen their power, so that they can squeeze a higher price from private payers and also lobby for more government handout in the future. And also, I want to just remind everyone, don't forget, these nonprofit hospitals did not really increase their effort to increase the charity care during the pandemic. And the charitable mission is the reason why these hospitals, nonprofit hospitals, receive tax-exempt status. Right? They don't pay property tax, income tax, they got low interest bonds, and then they receive tax-deductible charitable contributions. So these are all taxpayer subsidies. So what we found from the report is that these hospitals, failed to meet expectations of taxpayers. So thank you very much.
Thank you so much. And I'm going to turn it over to North Carolina State Representative Alan McNeil to talk a little bit about his own experience with how this affected rural healthcare. Thank you. I'm so sorry. I am staring at an old copy of an agenda because I made a typo. I would like to turn it over to Dr. Dale Owen, who is extremely well known nationally for breaking away from Atrium Health in Charlotte and starting one of the largest independent physician practices. Dale, please take it away. Thank you so much, and sorry about that.
No problem. Thank you, Julie. So here in Charlotte, as Julie mentioned, we were 88 physicians that left Atrium Hospital in 2018. We're now 105 physicians, have over 180,000 patients. And one of the things that I feel the most discouraged about in regards to this this meeting today and why we're having to have it and the report is that the power that's gained by the hospital systems as a result is not only used to strengthen their own market, but it's also used to acquire independent physicians. And over the pandemic, we've seen a significant decrease in independent physicians across the nation. We've remained very stalwart in remaining independent, and I think that that's important because we're also driving down the cost of care by an excess of 15 as high as 25%. And I think that that's an important role that's been alluded to, is that this is a big socioeconomic effect as well, because employers are having to pay more in healthcare dollars, and salaries as a result can't go up as much. And it affects the public all the way to the very end at that level. Thank you.
Thank you so much, Dr. Owen. I am now going to return it over to North Carolina State Representative Alan McNeil. Thank you.
Thank you. As I said earlier, Randolph County is a rural county and has struggled basically the last 10 years to maintain hospital coverage for the 145,000 residents in Randolph County. Many years of operating losses took their toll. The article published today by Christopher Rowland of the Washington Post explains in more detail some of the timeline of that struggle. Several years ago, I, Representative Hurley, and Senator Tillman, who's retired now, and other representatives, as being representatives of Randolph County, were contacted by hospital officials and county commissioners to explore our ideas to save Randolph Hospital and secure health care for our citizens. There were many suggestions, a lot of meetings, but we did not automatically default to a government bailout. For sake of time, I won't discuss everything from that timeline, but I will point out one meeting that really stood out to me. At this meeting, there was almost every large healthcare entity from North Carolina in attendance, all in the same room. They were asked to meet us with the hopes that one or all would help us with any plan to rescue Randolph Hospital. We were looking for any help that we could get from what I believed were people who would care and were financially able to help. What happened from that meeting was absolutely nothing. It seemed to me that they didn't care if Randolph Hospital failed. So having exhausted other ideas, we turned to the best option with the understanding that, we turned to other ideas to determine if a grant or a loan to help rural hospitals would be possible. After much consideration, much talk to leadership in the House and the Senate, we decided the best option would be a loan program. With the understanding that the loan would not go directly to the hospital and that the struggling hospital would have a reasonable plan for a successful future outcome. That is when Senate Bill 681 was filed. It was filed in June of 2019 and became law in July of 2020. Throughout all that time, the hospital continued to struggle. There were meetings, discussions, and a lot of debate during that time on rural health care. COVID came along and made everything worse for everyone. The $14.5 million that Randolph Hospital received in federal COVID relief, however, did help keep the doors open. But that's about all it did. It helped keep the doors open. It basically kept them from filing bankruptcy just a little bit before they did. But anyway, Randolph Hospital eventually filed for bankruptcy and fortunately found someone willing to help with struggling rural hospital. Unfortunately, that help did not come from any person or any entity from North Carolina. A newly formed company from California called American Healthcare Systems successfully won the bid from bankruptcy court to purchase the assets of Randolph Health, and all the details were finalized in July of 2021. The loans offered in the Rural Healthcare Stabilization Act were crucial in securing interest of potential bidders. Randolph Hospital will soon celebrate 1 year of operation outside of bankruptcy. So far, so good. But in the process of all this, Randolph Hospital went from a nonprofit entity to a for-profit entity. It still remains to be seen how this business model will thrive in years to come. So we celebrate a small win for rural healthcare. Randolph is still operating with patients, patient care, and emergency care. But debate continues on how we will keep our rural hospitals from closing. The larger hospitals place physician practices in these rural areas, which is good to some degree. However, when elective procedures or hospital care is needed, patients are sent to those hospitals, leaving the rural hospitals struggling to find patients. How do we help the hospitals out there right now that are struggling to keep their doors open? We all know that if the hospital goes, doctors' practices will be the next to leave. I, for one, hope the answer can be found right here in North Carolina. And the answer should not be to make our citizens drive 45 minutes to an hour for medical care. You will have to take the information you see and hear today and decide for yourself. Are large healthcare systems getting rich while rural hospitals close? Thank you.
Thank you so much. I'm now going to open it up for questions. We're going to toggle between in person in the room and also the folks who are joining us virtually. If you're joining us virtually, please use the chat box and I will read your question out loud. Thank you so much. And also please let us know who you would like to direct the question to if you have a specific person. We're going to start with you. Oh, sorry, Representative Richardson.
This is an incredible gap. This is a big gap between the rural and the large hospitals. Why is there such a gap there? I mean, I know that there's specialty coverages. Is the specialties making that much more money? What's causing this gap?
Well, the gap is because the large healthcare systems in North Carolina want there to be a gap. And that's what's created what we have now. When you heard the testimony from Representative McNeil, what he didn't say regarding this gap between rural and urban hospitals and these monopolistic cartel-like entities. What he didn't mention is that in many instances, when they do go into rural North Carolina, they end up turning these institutions into glorified emergency rooms. And then everybody gets airlifted, everybody gets ambulanced to the mothership, so to speak. So that's not a direct answer to your question. We will get a direct answer to your question, and Dr. Bai or Marilyn may have an answer for you.
I have a follow-up.
Yes, Dr. Bai.
All right, can you please repeat the question? Because we couldn't hear it from, yeah.
The question is, why is there this gap? I mean, a hospital, to me, this is just my limited brain. A hospital is a hospital. And so why, when they're getting the funding that they're getting, why is there this huge gap between the larger hospitals and the smaller hospitals? Is it because of the specialty funding, or is it, I just don't know. I don't see how that can be, that gap can be that big.
Yeah, thank you. That's a great question. So Marilyn knows more details, but my understanding is the allocation process has several steps. And several of the steps are based on the size of the operation. So if you're bigger, you just automatically get more money from the federal government. So that creates itself, the methodology itself creates a disparity. There's some future fund, more based on infection, etc. But the big chunks are literally allocated that way. In my opinion, it's quite arbitrary, and really do not take into the needs of the community. Eventually, it becomes powerful, richer, get more, and smaller, less powerful, get less. Thank you.
And Representative Richardson's got one follow-up question, then we're going to let Marilyn answer the first question. Go ahead, Representative.
I thought that the smaller hospitals were owned by the bigger hospitals, and they would use that funding that they got to help supplement the care in the smaller rural hospitals. But they're not using that funding for that, are they? I guess they're taking the money and putting it into profits, I guess. But they're not supplementing the small rural hospitals that they own. Is that right?
Yes, I think that's what we typically see. There were no requirements for how the provider relief funds be spent. The concept was to cover additional expenses or lost revenues. We've seen some systems in other states that all the money went to the mothership and then was delegated down. The actual payments of provider relief funds were based on percentages of Medicare patients, etc. What we see a lot, and I'll ask Dr. Bai to confirm this, but what we do see is that these larger health systems that own hospitals in these smaller rural areas more treat them as a referral site. So then when people do come into these smaller hospitals, they're referred on up to the specialists in the larger hospital or the procedures in the larger hospital. And it's not that the money goes the other way.
And Representative Richardson, I would add, when I use the word about a cartel, Gene Woods the head of Atrium signed the paycheck of the CEO of Cone Health. That person signed the paycheck of the CEO of Randolph Health. That's how convoluted this is. The CEO of Atrium signed the check of Terry Akins at Cone Health, and Terry Akins signed the check of the CEO of Randolph Health. This is some of the things that were uncovered.
So the resources are there to supplement and make sure that these rural hospitals stay open if they choose to do that.
If they choose to do that. We, this General Assembly, the citizens of this state, the private employers of North Carolina, we are allocating enough billions of dollars per year collectively that we should have transparent, accessible, high quality, low cost healthcare in this state.
Hi, Marilyn. He just asked if the resources are there for to keep rural healthcare alive if the large systems chose to do so. Would you mind talking a little bit about what we found on terms of the profit margins historically and in 2021, and especially the growth in cash and investments?
Certainly. We looked, and the paper includes some charts and some graphs that are easier to read. But what we found was that the funds that were received, a lot were put into investments, whether it be equities, bonds. One particular health system has quite a bit in private equity and hedge funds. So we saw that money invested in different mediums than investing in the rural hospital care or the money transferring that way. I'm not sure I answered the question.
Sorry, and just to be clear, that she means the investments were allocated, not the COVID relief. We cannot track,
Yes.
we have no way of tracking the COVID relief dollars right now. We have no idea what happened to them.
Yes.
I
We
was
do
just
know
asking
in-
a little bit about the large hospitals' resources financially. In the response to the Washington Post article, the Hospital Association talked a bit about how they need this money for reserves. Would you sort of mind answering that, I guess, is what I was asking. Sorry.
Well, I found that kind of interesting because one of the comments in there is that they need to keep their reserves to keep their bond ratings low. And that's an interesting phenomenon because all the municipal bonds are revenue bonds. So the security is future revenues, although the rating agencies do look at reserves. But I looked particularly at Atrium, and as the treasurer noted, it ended 2021 with about close to 12 billion in the combined reserves. But the bond debt with the combined entities is about 3 billion. So even if they wanted to say, you know, we need to secure that bond rating, really their net is pretty darn high. So I didn't understand on twofold is from a just purely financial standpoint, there is a lot of excess reserve there that can be spent on other items. The second part is this is a not-for-profit system. This is a tax-exempt system, as Dr. Bai explained. This is a system that is not paying the taxes for your state or federal. And in lieu of paying taxes, they are providing community benefit. And as the work showed, it wasn't spent on charity care. So really, I didn't understand their argument.
I'm going to start for the first question online from Jason DeBrin with North Carolina Public Radio. He wants to know, he says, I know hospitals will point out a lot of these profits are from non-operating accounts driven by big gains in the stock market that can fall again and are falling right now. Can you talk about why you included non-operating gains in your analysis? Who would like to take that?
I can take that. I wanted to say non-operating gains and losses are reflected in the charts on net income, but are not in operating income. We also included those gains because that was the value of those assets on that particular day. They can go up, as you've seen, they will fluctuate, but they can go back up too. So I think if you look at operating income, they're not included. Net income, they are. And I think it's the investment policy of that hospital to determine how they want to invest those funds to really maybe maximize profits. And the question would be for what? Or how they want to use that going up. But that's standard business, I would say. Dr. Bai?
Thank you. And it's a great question. So if we want to know an entity's overall financial viability, we should look at the bottom line, right? Which is the overall margin, including both operational and non-operational activities. If you only look at the operating activities, the average is probably -5% in US hospital, including government, nonprofit, for-profit. But does that really tell us an accurate picture? No, because if you look at the overall margin, which includes the non-operating activities, the margin is much higher. We already published a paper on JAMA Health Forum last month. So the point is, if we want to understand hospitals' financial status, we should really dig deeper into the overall margin, including the non-operating activities. Think of a parking lot, receipts, rental from professional buildings, charitable contributions, and most importantly, government appropriations, in this case, COVID funding and related allocations. So that will give us an overall picture of how the hospital is doing financially.
I would just add, this is Treasurer Falwell, that Jason's question goes right, is the correct question. And the answer is these entities who disguise themselves as nonprofits have lost their mission. They have turned into stock market, private equity, and real estate development firms versus healthcare firms. And it's very important to realize that as we talk about this topic, we're talking about whether these are stock market gains or not. We're talking about the fact that every time they get bigger, they're able to swallow up more and consolidate more healthcare in North Carolina. Healthcare now controls North Carolina, and Big Wall Street is now controlling healthcare. And that goes directly to Jason's question.
Thanks so much.
Joseph Holloway, CBS 17 in Raleigh. First of all, now obviously, actually kind of going off of what you were just saying right there, do we know anything about how these hospital systems are spending all of this money if they're not actually spending it on one in the rural hospitals or even on patient care?
I would answer your question by showing you something most people in this room have seen at least 10 times. We have no clear look as to what they're spending their money on. And by evidence of what I'm getting ready to show you, which was the master price list that was sent to me as the state treasurer, we don't know what things cost either. This was the document sent to me when I tried to determine what I'm spending billions of dollars of taxpayer and personal money of those that teach, protect, and otherwise serve. When I've attempted over the last 4 years to find out what things cost, not just what they spend, this is what was returned to me as the master price list.
Carolyn, would you like to, Bai, would you like to add to that? I would also, before turning it over, like to note that on page 8 of the report, Atrium noted that its net profits during 2020 would have been higher had it not been for the merger with Wake Forest Baptist Health, which cost about $220 million, give or take. And if investments gains were as high as they were in 2019, which was a great year for Atrium on the investments. As its annual standing financial statement noted, quote, these decreases were offset somewhat by the recognition of $254 million of federal stimulus money in 2020. Marilyn, do you have any, or Margie-Bai, do you have anything to add?
I think that's a very, very good question. It varies. We dig into the financial statements. We also look at the Medicare cost reports. And what we find is the health systems are investing in a lot of different things. We do break down what the investments are in, whether they're equities, hedge funds, or you name it. One of my co-researchers made a comment on a hospital that, or this particular entity, that it really resembled a hedge fund with a hospital attached to it. Then we do see investments by acquiring physician practices. They're acquiring more of the downstream service providers so that they can do the labs, that they can, you know, take in the whole, almost monopolize that whole production chain. So we see them acquiring different businesses. So it's more of a business outside of healthcare that I would say that I see mostly in the other income and other expense. Dr. Bai?
Thank you. So, we are both accountants, Mary and I. We are putting really our accounting, bean counting function here. So think of money coming into a hospital. Very rarely you see it's very clear earmarked, putting a pot, and then every dollar goes out and you'll record it. No, that's not the way how to work. So it's going to the big pot and then being spent. So the evidence, the best evidence we can get is see where the cash flows out, right? We know the cash flows in from the government, but now we want to know where the cash flows out. That's exactly what Meredith mentioned. We know it did not really increase the charity care provision. I really did not go to the rural health, etc. But we did see an increased cash flow for mergers and acquisitions. So that is, to me, very accurate evidence to show that the money did go to the mergers and acquisition activity, as well as building up the reserve. Thank you.
Thanks so much. And we're going to now take a question from Teddy Rosenbluth from the News and Observer. He says, can you talk more about how you measured the decline of charity care in 2020? How do we know the decline isn't because of an overall decline in hospital use in 2020 because of the pandemic? Marilyn or Bai, would you like to take this one?
I think I'll defer to Dr. Bai, as that work was predominantly done by Johns Hopkins.
So the charity care is the numbers obtained from the cost report. So cost report has a very clear line item talking about charity care provision for both the uninsured and the insured, and divided by the total expense. But we have used that measure for several of our studies. So in other words, charity care provision divided by the total expense. If a hospital has a higher provision, you will see a higher charity care to expense ratio. So great question about the reduced utilization. Absolutely true. During COVID, people are less likely to go to hospitals to use service. However, don't forget the hospitals have 100% discretion to how they provide charity care. So they can make the charity care policy as generous or as stringent as they want. So for example, during COVID, not many people seeking care, but why we can, let's say, improve the eligibility criteria from, I'm just making up, maybe 200% to 500% federal poverty line, or expand the service scope so that I can use my pot of money earmarked for charity care. Maybe, hopefully it's higher because I got so much COVID fund to help more patients, not just the uninsured, but also the underinsured. Because we, right now we have a huge underinsured problem. Many low-income American workers are insured by the high deductible plan, right? Those workers are facing the 100% immediate consequence before they reach the deductible. So my point is, there are many different ways hospitals can adjust their charity care policy to improve their charity care provision. That's 100% within their own control.
And this is Julie leaping in as well. If you look back on the state health plan's website under What the Health, you're going to find another report that says some North Carolina nonprofit hospitals bill the poor. In 2020, we went through their audited financial statements, again with the help of Maryland and Rice University researchers, and found that some of the hospitals during the pandemic were billing as much as 80% of their bad debt to patients who never should have gotten billed, who were eligible for charity care. And the percentage of bad debt that was being billed to impoverished patients actually did rise significantly during the pandemic. Our data was extremely limited, but it was troubling. Treasurer, do you have anything to add to that?
I just wanted to add that all these reports are on our website, and we are unpacking a lot of stuff here. But the fact is that all this is connected. I mean, we are talking about a product that people don't want to consume because that would mean they're healthy. When they try to inquire what it costs, they're told it's none of their damn business. And then when they don't pay for this product they didn't want to consume and no one would tell them what it cost, then they're punished and their credit score is weaponized. I mean, that's what we're talking about. And it came up a few moments ago about the hospital association. I just want to remind the people who are listening to this that under both the Trump administration and the Biden administration, when both of those presidents issued executive orders to bring transparency to healthcare, they were sued by the hospital association. They lost not once, but twice. In their final comment in their loss in the Wall Street Journal, this demonstrates the arrogance of what we're dealing with. The American Hospital Association continues to believe that the disclosure of rates does not that patients don't understand will not lead them to make better decisions. That's what they said. The North Carolina Hospital Association, whoever compares what we're talking about as to sexy should be fired. There's nothing sexy about people not being able to see themselves out of poverty. There's nothing sexy about the fact that we are in a situation right now where the leading cause of bankruptcy in this country is things associated with healthcare billing. There's nothing sexy about the fact that even when people do have insurance, they feel like they're one out of network, one surprise bill, or one medical bill away from generational economic destruction. To describe this as sexy, whoever said that should be fired immediately from that organization because they don't have the finger on the pulse of what's really going on in this state when this transfer of wealth is happening, especially from the lower and fixed income people of this state to these multi-billion-dollar corporations. There's nothing sexy about that.
Sure. And we're going to try to speed it up because I know we're running out of time. Anyone in the room, do you have a question?
Travis Swain with WRAL. I want to better understand what you think the healthcare model in this state, in this country, should look like. Obviously, we've been talking about this for a long time. They're not going to do it themselves. The free market's not going to fix it. What do you think the model should look like? And given your party and you know the phrase radical socialism, how often I'm seeing that in my email inbox, how does it differ from what Republicans would describe as socialism?
Well, don't think I'm the most qualified person to answer the second question. I will tell you that every word has meaning, and we have lost the meaning of words. At the state health plan, conservative means to conserve. It means to get more out of less. The word liberal means to liberate, to set economically free. All we're trying to do on behalf of those that teach, protect, and serve is to conserve the resources that our employees and our taxpayers in this General Assembly are giving us so that we can liberate people to have upward mobility and the joy of achievement in their life. We don't have that currently. The model simply is to get rid of secret contracts, push the power down to the consumer so that the consumer can figure out the value and the price of whatever they're consuming. Travis, one day you'll be as old as I am and you'll realize that today is Senior Citizen Day at Food Line. So if you like shopping at Food Line, this is the day to go if you're as old as I am. Tomorrow is Senior Citizen Day at Harris Teeter. My point is, in 80% of our citizens' lives, especially those that teach, protect, and otherwise serve, in 80% of their lives, they know the value and the price of what they're getting, except with healthcare. And the reason that my voice is breaking is that I'm meeting with the corrections officers convention last week in Durham. I was standing in the shoes and I was looking in the eyes and the hearts of people. When everybody talks about back the blue, corrections officers are back the blue with a fence around them. Just visualize that. When we were talking about the average beginning state employee having to work 1 week out of every 4 just to pay the family premium associated with the largest purchaser of healthcare in this state. So they're having to make a decision between healthcare and mortgage, healthcare and energy, healthcare and food, and healthcare and maybe just living their life. That is completely unacceptable. And the healthcare cartel, which has become more cartelized over the last 4 years, is driving up the cost of healthcare in this state. HCA wasn't even in these statistics. Let's be clear about that. We all know the massive lawsuits that are going on in the Western North Carolina, class action suits, because the wheels are coming off of healthcare in Western North Carolina. Before it's even had its second birthday, we had one of the premier, independent, high quality, high access, and profitable hospitals in New Hanover County. And now we're hearing reports of people dying in the emergency room because the multi-million-dollar executives refuse to pay traveling nurses to actually attend to these people. This is happening right in front of our eyes. And the reason I get emotional about it is that it's like Coach K once said, there's some things that happen right in front of your eyes that are worth getting mad about. And this is one of them.
Travis, could I add to what the treasurer just mentioned in your question? One of the things that's really important here is that hospital systems should not own the referral source. And right now they own the physicians that refer to them.
Yes. What about a co-op model? To the gurus, what about, the electric, in the electric, you have co-ops that work very well, especially down in my area with the rural and the urban kind of combining. But the co-ops, the ratepayer is actually one of the stockholders. Would a co-op model work with a hospital?
I would say, in not having thought about that question, that the cartel would never go along with that concept. I mean, the cartel has given the finger to both the previous and the current president of the United States regarding their executive orders. So the cartel, which controls the supply of this product through the certificate of need, pronounced CON, by the way, they control the quality, they control the access, they control the price, and then they control whether they penalize and weaponize your credit score because of this product that none of us really want to consume. They're never going to go along with the co-op model. And but that is a great idea, and it leads me to tell you, Representative Richardson, and everybody is listening, our door, our mind, and our hearts have been open on actually how to solve this problem. We're not here to attack people, we're here to attack the problem. And the problem is the transfer of wealth from the average person in this state to these multi-million dollar executives, multi-billion-dollar corporations. One more question.
So, Rose Hoban from NC Health News. To kind of piggyback off of what Travis was asking, it's still not clear in what you would see as the solution. Are you asking for increased thresholds for charity care, limits on investments, more free care by hospitals? I'm just trying to get a better handle on what it is you see as, a solution to this issue.
Great question. The solution is clear pricing, get rid of secret contracts, have reference-based pricing, which reflects nearly 100% profit margin over Medicare reimbursement rates, push the power to the consumer, stop weaponizing people's credit scores, and make sure that the charity care is commensurate with the tax benefit they're receiving in the state. That's the solution.
So, aside from what the Hospital Association has said, there's been prior research showing that when people are given a choice in terms of price, right, that they don't always follow the lowest price. They might follow their physician, right, where their physician, the hospital that they've practiced in. So will providing pricing fix all of this? What if providing pricing doesn't fix all of this?
Well, as I said earlier, anything that needs to be looked at, whether it's the co-op model or more further exploring what you're saying, needs to be addressed. I'm looking at a sheet here that shows just an appendectomy in this state at Cone Health can range between $6,000 and $29,000. A appendectomy at Baptist between $9,000 and $48,000. Novant between $2,700 and $25,000. An article in the Wall Street Journal that shows that a C-section in one hospital can cost between $6,000 and $60,000. My point is, how outraged would the people in this building be, from all genders, all races, and all political persuasions, if two people left this room and walked into a McDonald's and ordered the exact same thing, and based on what type of insurance card you presented, determined what range you paid. This is inexcusable and immoral.
Thanks, Treasurer Falwell. We have another question from online from the Carolina Journal, Teresa Opeka. She wants to know, Treasurer, I quote, is it ironic that there are calls to expand Medicaid in the state, given the fact that this report, especially not providing charity care like they should, expansion of Medicaid may not be needed at this time? What are your thoughts?
My thoughts have not changed. Being the state treasurer and the keeper of the public purse, obviously now I'm a protector of the consumer, means that this is very much like yoga. I pay attention to my mat. Let's talk about what Medicaid expansion really is. It's about increasing the access to health care. What we're trying to do is to increase the access to those that teach, protect, and serve. I cannot go to any meeting in this state where I don't meet someone who cannot afford to insure their kids and their spouses on the state health plan. As I said earlier, these people in many instances on entry-level positions are having to work 1 week out of every 4. So my job as the keeper of the public purse, and Dee and the state health plan's job, is not just to freeze family premiums, which we've been able to do for 5 years, but we need to lower family premiums. What happens when you lower family premiums? We get younger, healthier people on this plan to offset people like me. I mean, we're a self-insured insurance company. So the issue about Medicaid expansion is about increasing the access to health care. We are trying to do that through basic sound economics inside the state health plan. And I'm reminded as I close my remarks on that particular subject, we redesigned our state health plan card several years ago. And at the bottom of every state health plan card, it says paid for by you and taxpayers like you. The reason we're doing that is to send the message that every dollar that's inefficiently spent on health care by those that teach, protect, and serve is a dollar that can never be spent on public education, public roads, public works, or public safety. Every inefficient dollar spent on health care is a dollar that can never be spent on those basic things that people are waking up and worrying about every day.
Oh, sorry. Thank you, Treasurer. We're going to take a first question from Claire Donnelly with WFAE before jumping back to follow-up questions. What are you all hoping to achieve by releasing this report? What action are you hoping is taken, and by whom?
We're running out of committee time here, so ask it briefly, quickly.
What do you want, basically, what do you want to happen by releasing this report? What are you hoping to achieve?
Sunshine.
All right. I think we're going to go to closing remarks.
And that answer was not based on my disposition.
All right. I think we're going to go to closing remarks. Thank you so much, everyone.
Thank you. As I said earlier in my remarks, please read all these reports, any other information that you can get and see on these, and then make up your own mind. As the treasurer said, he's welcome to ideas. I'm welcome to ideas. Everyone in the legislature is welcome to ideas to fix this. Ultimately, it has been a discussion for a long time, and we do need to come up with a solution to save our rural hospitals. Thank you all for coming.